Okay, good day. My topic for today is about peptic ulcer disease. By the way, I'm Orlane Maribel D. Di Maunahan, RN. So first is the contents, starting from the definition, demographics or statistics, comparing gastric and duodenal ulcers, the etiology or the causes, signs and symptoms. It's either subjective and objective data, the differential diagnosis, diagnostic plan, the treatment plan regarding H. pylori and not H. pylori, the lifestyle changes, prevention, any complications, surgery, nursing management, nursing diagnosis or collaborative problem, patient and family teaching, evaluation or follow-up or referral, the journal or the evidence-based nursing, and lastly, my references. Okay, so let's start from the definition. Okay, peptic ulcer disease is an erosion of the gastrointestinal or the GI mucosa resulting from the digestive action of hydrochloric acid and pepsin. Any portion of the GI tract that comes into contact with gastric secretions is susceptible to ulcer development, including the lower esophagus, stomach, duodenum, and at the margin of a gastrojejunal anastomosis site after surgical procedures. By Dirksen and et al. 2007. So here, as you can see, it's a superficial peptic ulcer. This one. And for the definition of terms, as I said a while ago, so here are the common sites of peptic ulcer. Here, as you can see, this one, or the lesser curvature, is the gastric ulcer. And this one, here at the bottom, in the pyloric sphincter, is the duodenal ulcer. Next, it's the peptic ulcer disease demographics or statistics.
It's 11 o'clock.
Higher prevalence in developing countries. H. pylori is sometimes associated with socioeconomic status and poor hygiene. It's based on Ignatavicius D. and Workman M. 2013. And according to the latest WHO data published in 2017, public ulcer disease deaths in Philippines reached 6,784 or 1.10% of the total deaths. The age-adjusted death rate is 10.36 per 100,000. A population ranks Philippines number 8 in the world. So again, peptic ulcers can be classified as acute or chronic depending on the degree of mucosal involvement and gastric or duodenal according to the location. First is an acute ulcer is associated with superficial erosion and minimal inflammation. It is a short duration and resolves quickly when the cause is identified and removed. The other one is about a chronic ulcer is of long duration, eroding through the muscular wall with the formation of fibrous tissue. It is continuously present for many months or intermittently throughout the person's lifetime A chronic ulcer is at least 4 times common as acute ulcer. So again, if it's an acute ulcer, it is a short duration. But if it's chronic ulcer, it is long duration. Next is about gastric or duodenal ulcers. Although identified as peptic ulcers, are distinctly different in etiology, incidence, and clinical manifestations. Generally, the treatment of all ulcer types is similar, according to Dirksen et al. 2007. So before we discuss the difference between peptic ulcers, gastric and duodenal ulcers, let's have a short pathophysiology of peptic ulcer disease. So as you can see here, this is the normal gastric mucosa. For this normal gastric mucosa, in the stomach and duodenum, the mucosal barrier protects the gastric mucosa here, including the epithelial, vascular, and smooth muscle layers from damage. Specialized mucous cells throughout the gastric mucosa produce a mucus, a mixture of water, lipids, and glycoproteins that serves as a barrier to the diffusion of ions. A thin layer of bicarbonate secreted by surface epithelial cells here. The blood flow to the gastric mucosa is vital to maintain this barrier. So prostaglandins and nitric oxide stimulate mucus and bicarbonate production, helping maintain it as well. The mucosal barrier here constantly bats surfaces of the gastric epithelial lining. So next is about the disruption of mucosal barrier. So here, as you can see in the picture, for the disruption of mucosal barrier, it can be disrupted by a number of factors. Ischemia of the gastric mucosa due to hemorrhage, hypotension, or shock. Impairs mucose production, increasing the risk of damage. Here. Increasing the risk of damage to the mucus. Next is this one. The decreased prostaglandin due to aspirin, because aspirin disrupts the mucosal barrier and along with other non-steroidal anti-inflammatory drugs or the NSAIDs inhibits prostaglandins which are necessary to maintain mucus production. Alcohol and bile acids also damage the mucus barrier. Helicobacter pylori or the H. pylori, a common pathogen to infect the gastric mucosa, disrupt the mucosal barrier. So here, in the next picture is what we can see as the inflammatory process. So for the inflammatory process, when the mucosal barrier is damaged, gastric acid and digestive juices disrupt the epithelial cell membranes, allowing acid to diffuse into cell walls. An acute inflammatory process results gastric epithelial cells migrate to the damaged area, a process known as restitution, It is an adequate blood flow and an alkaline environment are necessary for this repair process. Prostaglandins play an important role in epithelial repair. In the presence of Helicobacter pylori or the H. pylori infection, excess acid production, inadequate blood flow, inhibition of prostaglandins here, the decreased perfusion. The inflammatory process further damages gastric and duodenal epithelial cells, leading to the ulceration of the mucosa. For the next picture, you can see the erosion and the ulcer formation. Here, this picture. For this picture, okay, the superficial ulcers or the erosions here erode the mucosa but do not penetrate the muscularis mucosae. Here, true ulcers extend through the muscularis mucosae and into the deeper layers of the gastrointestinal wall, damaging blood vessels and potentially penetrating the entire wall. Hemorrhage and peritonitis are potential acute complications of peptic ulcers. Okay, so for the brief description of pathophysiology, I can show you this one. So for this one, for this picture, as you can see, here, the conditions favoring the development of gastric ulcers are normal gastric secretion and delayed stomach emptying with increased diffusion of gastric acid back into the stomach tissues. Here, this one. But for this image, for this next image, here, in these conditions favoring the development of the duodenal ulcers. A while ago, I discussed about gastric ulcers. So what's the difference? Next is the duodenal ulcers. For the duodenal ulcers are normal diffusion of acid back into the stomach tissues with increased secretion of gastric and increased stomach emptying. So now that we know the pathophysiology of gastric and duodenal ulcer, let's see and compare. Again, here is the duodenal ulcer, and here, this one is the gastric ulcer. So for this slide, the duodenal ulcers, first, the duodenal sites are 4 times as common as gastric sites. Most common in middle age, peak 30 to 50 years old. Male to female ratio, it's 4:1. Genetically linked, 3 times more common in first-degree relatives. It is more common in patients with blood group O. Associated with increased serum pepsinogen. H. pylori infection common up to 95%. Smoking is twice as common. This is about, it's according to Smeltzer SC and Bear B 2003. While gastric ulcers, it is common in late middle age, incidence increases with age. So a while ago, the ratio for duodenal ulcer is 4:1 for male to female ratio, but if for gastric ulcers, it's 2:1. gastric ulcers is also more common in patients with blood group A. Again, duodenal ulcer is for blood group O. For gastric ulcers, use of NSAIDs associated with 3 to 4-fold increase in risk of gastric ulcer, less related to H. pylori than duodenal ulcers, about 80%. 10 to 20% of patients with a gastric ulcer have a concomitant duodenal ulcer. It's also according to Smeltzer SC and BRB 2003. Next, let's know about the etiology or the cause of the peptic ulcer. A peptic ulcer is a mucosal break, 3 mm or greater, that can involve the stomach or the duodenum. The most important contributing factors are H. pylori, NSAIDs, acid, and pepsin. Additional aggressive factors include smoking, ethanol, bile acids, aspirin, steroids, and stress. And important protective factors are mucose, bicarbonate, mucosal blood flow, prostaglandins, hydrophobic layer, and epithelial renewal. It is also increased risk when older than 50 DT or decreased protection. When an imbalance occurs, peptic ulcer disease or the PUD might develop. It is according to Dewitt SC 2009. Next is it's for the subjective data or the signs and symptoms of peptic ulcer disease. For the pains, the gnawing, aching, or burning. So let's also know the difference between the duodenal ulcers pain and the gastric ulcers. For the duodenal ulcers, it occurs 1 to 3 hours after a meal and may awaken patient from sleep. Pain is relieved by food, antacids, or vomiting. But for gastric ulcers, food may exacerbate the pain while vomiting relieves it. So other signs and symptoms: nausea, vomiting, belching, dyspepsia, bloating, chest discomfort, anorexia, hematemesis, and or melena may also occur. For nausea, vomiting, and weight loss, it is more common for gastric ulcers. And for objective data, it's the epigastric tenderness. Next, the guaic positive stool resulting from occult blood loss. Then, what's the suction splash? It is resulting from scarring or edema due to partial or complete gastric outlet obstruction. It describes the sound obtained by shaking an individual who has free fluid and air or gas in a hollow organ or body cavity. It is usually elicited to confirm intestinal or pyloric obstruction, done by gently shaking the abdomen by holding either side of the pelvis. A positive test occurs when a splashing noise is heard either with or without stethoscope. It is not valid if the patient has eaten or drank fluid within the last 3 hours. Next, let's know about the differential diagnosis. First is neoplasm of the stomach, pancreatitis, pancreatic cancer, diverticulitis, non-ulcer dyspepsia, or also called functional dyspepsia, cholecystitis, gastritis, GERD, myocardial infarction or MI, not be missed if having chest pain. Next is for the diagnostic plan. First, the stool for fecal occult blood lab test. So what we should do is for the CBC, for bleeding, liver function test, amylase, and lipase. For Helicobacter pylori or H. pylori can be diagnosed by urea breath test, blood tests, stool antigen assays, and rapid urase tests on a biopsy sample. Other diagnostic tests, upper GI endoscopy. Any patient greater than 50 years old with new onset of symptoms or those with alarm markings including anemia, weight loss, or GI bleeding. It is preferred diagnostic test because it's highly sensitive for diagnosis of ulcers and allows for biopsy to rule out malignancy and rapid urase test for testing for Helicobacter pylori. It is according to Dirksen et al. 2007. Next, there are two types of treatment plan. It's based on with Helicobacter pylori and not Helicobacter pylori. But first, let's discuss about with Helicobacter pylori. Here are the medications. Triple therapy for 14 days is considered the treatment of choice. Here, the PPI, or what we call the proton pump inhibitor, plus the clarithromycin and amoxicillin. Here are the sample medications: omeprazole, lansoprazole, labreprazole, esomeprazole, clarithromycin, amoxicillin, and here are the dosage. Then can substitute with flagyl 500 milligrams per orum twice a day for 14 days if allergic to PCN. In the setting of an active ulcer, continue proton pump inhibitor or the PPI therapy for additional 2 weeks. Our goal is to complete elimination of Helicobacter pylori. Once achieved, reinfection rates are low. It's compliance. And this is the difference between the treatment with not Helicobacter pylori. Here are the medications. The treatment would be proton pump inhibitors or the PPI or H2 receptor antagonists to assist ulcer healing. Here are the sample for H2 and PPI. For H2, we have the Tagament, Pepcid, Acid, or Zantac for up to 8 weeks. Then for the PPI or the proton pump inhibitors, we have the Priloxec, Prevacid, Nexium, Protonix, or Acipex for 4 to 8 weeks. For the lifestyle changes, so let's discontinue the non-steroidal anti-inflammatory drugs or the NSAIDs and use of acetaminophen for pain control if possible. Next, acid suppression, antacids, smoking cessation, no dietary restrictions unless certain foods are associated with problems. Then alcohol in moderation for men under 65, 2 drinks per day. Then men over 65 and all women, 1 drink per day. Lastly is the stress reduction. For the next slide is for the prevention. First, let's consider the prophylactic therapy for the following patients. Patients with NSAID-induced ulcers who require daily NSAID therapy. Next, patients older than 60 years. Third, patients with a history of peptic ulcer disease or a complication such as gastrointestinal bleeding or GI bleeding. The last one is patients taking steroids or anticoagulants or patients with significant comorbid medical illnesses. Another prevention is the prophylactic regimens that have been shown to dramatically reduce the risk of NSAID-induced gastric and duodenal ulcers, induce the use of prostaglandins analog or the PPI or the proton pump inhibitor. Here, the misoprostol, omeprazole, lansoprazole. Next is what are the complications? First, the perforation and penetration into pancreas, liver and retroperitoneal space, peritonitis, bowel obstruction, gastric outflow obstruction, and pyloric stenosis. Next, bleeding occurs in 25% to 33% of cases and accounts for 25% of ulcer deaths. Gastric CA. Next is for the surgery. So people who do not respond to medication or who develop complications. First surgery is what we call the vagotomy. So what's vagotomy? It's the cutting the vagus nerve to interrupt messages sent from the brain to the stomach to reducing acid secretion. Here's the sample of various types of vagotomies. As you can see, here's the selective, this is the truncal and the proximal or parietal cell. Next surgery is the anthrectomy. What's anthrectomy? It removes the lower part of the stomach, antrum, which produces a hormone, excuse me, that stimulates the stomach to secrete digestive juices. Then pyloroplasty. The opening into the duodenum and small intestine are enlarged, enabling contents to pass more freely from the stomach, may be performed along with a vagotomy. So for the nursing management, our goals, the overall goals are that the patient with peptic ulcer disease will comply with the prescribed therapeutic regimen, experience a reduction or absence of discomfort, exhibit no signs of GI complications, have complete healing of the peptic ulcer, and make appropriate lifestyle changes to prevent recurrence. It's according to Dirksen et al. 2007. So for the nursing diagnosis or collaborative problem, we have the acute pain, ineffective therapeutic regimen management, nausea, potential complication, or the perforation of the GI mucosa. It's according to Limon and Bork, 2008. So here, as you can see, for the NANDA, NIC, and NOC linkages, is the client with peptic ulcer sample, ineffective health maintenance. For the NIC, it's the medication management, nausea management, fluid electrolyte management, teaching, this is process, and for NOC, it's the comfort level, the nutritional status, food and fluid intake, hydration, and knowledge status, treatment regimen. Excuse me. Next is for the patient and family teaching. General instructions for newly diagnosed patients and their family should cover aspects of the disease's process itself. Nutritional therapy and medication, possible changes in lifestyle, and regular follow-up care. So here are the samples for the patient and family teaching. First is explain. We nurses must explain dietary modifications, including avoidance of foods that cause epigastric distress. This may include black pepper, spicy foods, and acidic foods. Small frequent meals are better tolerated than large meals. Explain the rationale for avoiding cigarettes. In addition to promoting ulcer development, smoking will delay ulcer healing. The third one, so let's encourage the need to reduce or eliminate alcoholic ingestion. Fourth one, explain the rationale for avoiding OTC, or what we call the over-the-counter medications. unless approved by the patient's care provider. Then the fifth one, teach the need to take all medications as prescribed, because failure to take that medications as prescribed can result in relapse. Sixth one, explain the importance of reporting any of the following: increased nausea and or vomiting, increased epigastric pain, bloody emesis or tarry stools. Seventh, explain the relationship between symptoms and stress, because stress reducing activities or relaxation strategies are encouraged. Then the last one, encourage patient and family to share concerns about lifestyle changes and living with a chronic illness. It's according to Dirksen et al. 2007. So for the evaluation or follow-up or referrals, H. pylori positive retesting for treatment efficacy, urea breath test no sooner than 4 weeks after therapy to avoid false negative results. Stool antigen test, an 8-week interval must be allowed after therapy. H. pylori negative evaluate symptoms after 1 month. Patients who are controlled should continue 2 to 4 more weeks. If symptoms persist, then refer to a specialist for additional diagnostic testing. So before we proceed to the updated journal related to peptic ulcer disease, I will show you here the difference between, it's the brief description, the difference between the gastric ulcer and the duodenal ulcer. Here's the comparison. Here, for the lesion for the gastric ulcer, the superficial smooth margins round, oval, or cone shape. While for duodenal ulcers, penetrating associated with the deformity of the duodenal bulb from healing of recurrent ulcers. For the location of lesion, a while ago, I showed you the location, if it's gastric or if it's duodenal. For the location of gastric, it's predominantly antrum, also in the body and fundus of the stomach. But if it's duodenal ulcer, it's first 1 to 2 centimeters of the duodenum. So for the gastric secretion, for the gastric ulcer, it's normal to decrease. But for duodenal ulcer, it's increased. For the incidence for the gastric ulcer, again, let's review. Greater in women. Peak age is 50 to 60 years old, more common in persons of lower socioeconomic status and in unskilled laborers. Next, increase with smoking, drugs, aspirin, NSAIDs, and alcohol use. Then increase with incompetent pyloric sphincter and bowel reflux. While duodenal ulcers, here are the incidents. It's greater in men, but increasing in women, especially postmenopausal. Peak age is 35 to 45 years old. Associated with psychologic stress, increase with smoking, drugs, and alcohol use. Associated with other diseases, example, the COPD or the chronic obstructive pulmonary disease, pancreatic diseases, hyperparathyroidism, or the CES or the Zollinger-Ellison syndrome, and chronic renal failure. Okay, so now let's proceed to the updated journal related to peptic ulcer disease. Here, this is the last portion of my report. The title of the journal is about peptic ulcer disease, a brief review of conventional therapy and herbal treatment options. Reference Kuna L. et al. 2019. So let's have a short description of that journal or the abstract. The peptic ulcer is a chronic disease affecting up to 10% of the world's population. The formation of peptic ulcers depends on the presence of gastric juice pH, and the decrease in mucosal defenses. NSAIDs, or the non-steroidal anti-inflammatory drugs, and H. pylori, or the Helicobacter pylori infection, are the two major disrupting the mucosal resistance to injury. Conventional treatments of peptic ulcers such as PPI, or the proton pump inhibitors, and H2, or the histamine 2 receptor antagonists, have demonstrated adverse effects, relapses, and various drug interactions. On the other hand, medicinal plants and their chemical compounds are useful in the prevention and treatment of numerous diseases. Hence, this review presents common medicinal plants that may be used for the treatment or prevention of peptic ulcers. So this journal is very important and significant for the latest peptic ulcer disease treatment or clinical management. And lastly, here are my references for my discussion for peptic ulcer disease. First, the with SC 2009 Medical Surgical Nursing Concepts and Practice, Saunders Elsevier. Second reference, Dirksen, O'Brien, Lewis, Haight, Kemper, and Butcher 2007. The title of the book is Medical Surgical Nursing Assessment and Management of Clinical Problems, 7th edition. My third reference is Ignatievicius D. and Workman M. 2013. Title of the book, Medical Surgical Nursing Patient-Centered Collaborative Care, it's 7th edition. Elsevier Saunders. My fourth reference is about my journal, or Kuna L. Jacob J. Smolik R. Ragus Lusik N. Visev A. and Smolik M. 2019. Again, the title of the journal is Peptic Ulcer Disease, a brief review of conventional therapy and herbal treatment options, Osijek, Croatia, retrieved from 10.33390/JCM 8880200179. My fifth reference is Lemon P. and Burks K. 2008. Title of the book, Medical Surgical Nursing Critical Thinking in Client Care, 4th edition, person. And lastly, Smeltzer S.C. and Bear B. 2003. Textbook of Medical Nursing, 10th edition, Lipin, Williams, and Wilkins. So all in all, here are my references. You can go to the library and search these references. And for my journal, you can just click here, the link I insert here. Then if you have any further questions, comments, or suggestion, you can also message me. Again, my topic is about peptic ulcer disease. Thank you for listening. And that's all. Thank you and God bless. I'll end my video here. Bye.